So coming to first OSCE, are you able to see everyone?
Yeah, it's seen clear.
Okay. So describe this lung USG finding and the condition where it is seen. So you can answer in the chat box. Lung USG finding and the condition where it can be seen. Yes, Pradeep Sharma, it was TTNB and lung point seen, double lung point, okay. Double lung point TTNB, double lung point TTNB, yes. I can see everyone answering nicely.
It's good that most of them
Yeah,
are familiar with the lung.
familiar with lung and lung USG also. Yes.
That's good.
Oh,
Wonderful.
yeah, it is correct. It is TTNB and you are seeing the double lung point. Okay. So this is how we see the normal lung USG. So first it is the skin, subcutaneous tissue, and the ribs, the hyperechogenic regions of the ribs in between intercostal muscles, and these are pleural line. And this is acoustic shadow in the lung that is caused by the ribs. Normally, we see two types of lines in the lung USG. One is A lines and B lines. A lines are normal. We see in the normal lung USG. So these are horizontal hyperechogenic lungs that are equidistantly placed, and that is a reflection. Okay, it is an artifact that is produced due to ultrasound waves reflected between the pleura and the transducer. A lines are horizontal lines and equidistant lines, hyperechogenic equidistant lines, and so those are normal lines. When these are A lines. Okay. So other thing is B lines. These are pathological. So these are what B lines are vertical lines, hyperechogenic lines extending from the pleura distally to the far field without fading, and they erase the A lines and they move synchronously with the lung sliding. So the B lines are seen due to accumulation of the lung fluid in the interlobar septae, and the B lines are normal, like seen in TTNB, pulmonary edema and pneumonia. So it may be normal in the newborns in the first 48 hours or longer in the premature infants. Okay. So as all of you said correctly, that's a TTNB double lung point. Why we see a double lung point in the TTNB is a difference in the echogenicity in the upper and the lower lung field images. So, but severe TTNB cases can have a white lung appearance. Double lung point is usually seen in milder case of TTNB. Okay. So, whereas white lung or B line pattern signify more severe disease. So in TTNB double lung point, so echogenicity, this upper lung field and the lower lung field, there is a difference in the echogenicity. Upper lung field is improving and lower lung field has severe B lines, are still wet and it is composed of B lines. Okay, this is it. And this is the image we have seen. All of you said correctly. This is the upper lung field and this is the lower lung field. Upper lung field, there is clearance and the echogenicity is improving, and lower lung fields as still having B lines. So this is a case of TTNB and we are seeing the double lung point. Okay. Coming to second OSCE, it is regarding the antenatal medication, antenatal magnesium sulfate administration. What is the indication for the antenatal magnesium sulfate indication? What is the dose and what is the pharmacological action? Also, tell about the evidence. You can answer in the chat box. Okay, indication less than 32 weeks, neuroprotection, excellent. Okay, 32 weeks, neuroprotection. You can tell about the pharmacological action, also evidence. Yeah, 4 grams stat, 1 gram per hour, it's correct. Yes, preterm less than 32 weeks, neuroprotection, 4 gram loading followed by 1 gram per kg per hour. Yes, okay. Till 24 hours or till delivery, whichever is longer. Yeah. Inhibition of NMDA receptors. Yes. Okay. So, women at risk for preterm birth between 24 and 32 weeks of gestation. Okay. So, and it is administered at 4 gram IV loading dose over 30 minutes, followed by 1 gram per hour maintenance infusion until birth or for a maximum of 24 hours. The mechanism of action is, it blocks the NMDA receptors. Okay, it blocks the NMDA receptors, thereby influx of the calcium, and it acts as an anti-excitatory, antioxidant, and anti-cytokine also. It decreases the inflammatory cytokines like tumor necrosis, interleukins, and it acts as an anti-cytokine and also it has antiplatelet effects. The main action is it blocks the NMDA receptors, as you said. Okay. So evidence says that when given with neuroprotective inhibition, it decreases the cerebral palsy by about 29%. The meta-analysis has showed it decreases the cerebral palsy by 29%, as well as it reduces the outcome of death, combined outcome of death and cerebral palsy by about 15%. This cerebral palsy at 2 years of age. Okay, decrease the cerebral palsy at 2 years of age by 29%. Okay, and the number needed to treat is 63. Okay. Yeah, everyone said correctly about magnesium sulfate. Coming to next OSCE. So, a 28-day-old admitted with a heart rate of 240 per minute, diagnosed as neonatal narrow complex tachyarrhythmia. What is the drug of choice? Yeah, it is supraventricular tachycardia, adenosine. Everyone is so fast. Adenosine, yes. IV, okay. Two flush technique, yes. Okay, so you said correctly, it is adenosine and the dose is 50 microgram per kg. And if no response, we can increase to a maximum of 250 microgram per kg. It should be given as a rapid infusion like rapid bolus because it is a very short acting drug and the half-life is only just 10 seconds. So we have to give very fastly. We have to give very fast and by rapid infusion over 1 to 2 seconds and followed by a rapid flush. Okay, the 3-way stopcock. Okay, because it is short acting, we have to give very fast. It is adenosine, it is supraventricular tachycardia. Mechanism of action of adenosine is it acts on the AV node and it decreases the conduction of the AV node. It normalizes the cardiac rhythm. Okay, it normalizes the cardiac rhythm and it interrupts the re-entry mechanism. Okay, AV nodal re-entry mechanism and it acts on the AV node. Coming to next OSCE, it is about pasteurization. Okay. So you have to just say whether it is a true or false. Okay. So after pasteurization, the first question is whether the human milk oligosaccharides are reduced after pasteurization or not. Oligosaccharides are reduced. Okay. Okay. Proteins. Protein, no. Okay.
You all can write the number and the answer. Question number 2, true or false, in that way you can mention.
Okay. You have written like oligosaccharides, yes, and proteins are no. And any like growth failure with prolonged pasteurization. Question number 3. Third is true. Okay. And DHM has no effect on immunonutrients. Question number 4. Okay, false. Next, question number 5. Long chain polyunsaturated fatty acids in DHM preserved. True or false? No. Okay. Okay. You can see the answer now. Like after pasteurization, human milk's oligosaccharides are reduced. It is false. Okay, they are preserved. And proteins are reduced. Yes, proteins are reduced, and prolonged DHM is associated with growth failure. It is true. And DHM has no effect on immunonutrients is false. And long chain polyunsaturated fatty acids in DHM is preserved. It is true. So proteins are reduced, whereas oligosaccharides are preserved. And long chain polyunsaturated fatty acids are preserved. So this is a table you can see. So maintained more than 90% even after pasteurization of breast milk, like carbohydrates, oligosaccharides are maintained. Whereas the protein is reduced, like protein is maintained at 50 to 90%. What is completely abolished is the cellular components like immune components like IgM lymphocytes and bile lipases, lipoprotein lipase. And almost abolished is lysozyme lactoferrin. Okay, hepatocyte growth factor. What is preserved is oligosaccharides. Okay, oligosaccharides and lactose, and like fat and protein is maintained at 50 to 95%. Protein content is reduced, but still it is maintained at 50 to 90%. Okay, you can see this table. So coming to the next OSCE, it's about HIV. This also four questions. Risk of HIV transmission from mother to child with or without intervention, like breastfeeding. Like only two questions. Breastfeeding with 3 ARVs, no breastfeeding with 3 ARVs. What is the incidence of HIV transmission from mother to what is the percentage of HIV transmission from mother to child? When the mother is giving breastfeeding with 3 ARVs, no breastfeeding with 3 ARVs. Okay, and what is the risk categorization for HIV infection in infants according to new NACO guidelines? NACO 2021 guidelines. What is the risk categorization for HIV infection in infants? Okay, and infant ARV prophylaxis regimen for high and low risk, and criteria for ensuring replacement feeding. Okay, no problem. We'll go ahead with the answer. So, risk of HIV transmission from mother to child when the mother is breastfeeding and also mother is receiving the antiretroviral regimen, it is 2% chance. And with mother is not breastfeeding and mother is on ART, it is only 1% chance of transmission. Yeah, someone attempted, Ashwini. Yes, it is 1% with no breastfeeding and 2% with breastfeeding when mother is on antiretroviral regimens. Okay. Sorry. One minute, I'm not able to share the screen.
Hello.
Hello, sir, I'm not able to proceed with the slides, sir, actually. One
more is there?
Yeah, one. This one more means this is the last OSCE actually. So we
Okay.
are categorizing the infants into high risk category and the low risk category. Low risk category when the mother is on, like when the mother is having a viral load of less than 1,000 copies at or after 32 weeks of gestation, and mother is receiving the antiretroviral therapy, those are low risk category. High risk category is mother was not tested and mother has a very recent infection and mother was not tested beyond 32 weeks, has a high viral load beyond 32 weeks of gestation, and mother did not receive any ART and mother was recently infected. This is high risk category, high risk infants and low risk infants. Okay. For low risk infants, we usually start with a single drug, whereas with high risk infants, we start a dual drug. So for low risk infants, we'll start the nevirapine single drug, and for high risk infants, we'll start with nevirapine and zidovudine. Okay. So nevirapine will continue till 6 weeks, 6 weeks of age for low risk infants, and for high risk infants, we'll give nevirapine and zidovudine. Okay. Like the dose is like for nevirapine, it is 1 ml once day, 1 ml per day. Like it depends on the birth weight. If it is 2 to 2.5 kg, it is 1 ml once daily nevirapine, and more than 2.5 kg, it is 1.5 ml. Zidovudine, it is 1.1 ml twice daily, and more than 2.5 kgs, it is 1.5 ml twice daily. Okay. And whenever we are giving the replacement feeding, it should follow the AFAS criteria. It should be acceptable, feasible, available, and safe. Okay. So it should be safe, it should be acceptable, it should be affordable, and it should be feasible. Okay. Replacement feeding, and mother can give exclusive breastfeeding. So when okay, sir. Sir, I'm not
Hello.
able to.
It's okay. That's fine.
Ah,
It's completed.
yeah, yes, sir. Completed, sir.
Uh, Yeah, I think this point you have to emphasize that breastfeeding with 3 ARVs to 3 without breastfeeding, there's just 1% difference in the transmission, especially if the mother is on ARV. So this we need to emphasize very clearly to the patients that breastfeeding, especially the mother is on ARV, it's not at all a big contraindication. So we should encourage breastfeeding even if the mother is positive and if she is on an adequate antiretroviral therapy. So this I think we should keep in mind before jumping on to formula feeding, because
Replacement feeding.
breastfeeding has got a tremendous benefits and the risk reduction is just 1%. Okay, it is almost just not a big number at all. So I think this point we need to emphasize. And thank you, Dr. Shravani, for bringing this point. Yeah. Thank you. Thank you, Dr. Shravani, for accepting to be faculty at a very short notice. And then
Thanks for giving me this opportunity, sir.
Yeah, and the OSCEs also you have taken up nice questions which are very less discussed. These are not very commonly discussed. I think this is really good. Thank you, and thank you, Dr. Parnika and Dr. Manan, for nice presentation. Thank you all. Thank you.
Thank you all.
So we'll close the session. Thank you.
Yes, thank you, sir.